Hi, welcome to the Symposium on Health Beliefs and Decision Making. Quite excited for the researchers today who all have backgrounds in basic cognitive science research, but we've all been applying it to the domains of health and medicine. Asking questions like, why do people believe the effectiveness of health treatments? How do they decide to engage in certain health treatments or other behaviors, right? Now, all of us have been working on these topics for a little bit, and it predates the current pandemic, but the current pandemic has certainly made these kinds of psychological principles quite salient in our minds, right? So some of this research that we're presenting today has been updated a bit for the current context, but generally the topics are actually quite evergreen, and hopefully we're getting at generalizable principles that can be applied to this context and elsewhere. Right. So the four talks today, Christine Laguerre starts off with some really interesting research in India, looking at perinatal risk, health risk. Then Zach Horn is going to talk about the media and the government and how that shapes people's vaccine attitudes. Right. I'm going to talk about people's beliefs in herbal medications. Right. And how to change those beliefs. And Amy Perfers is going to talk about Black Swan events and their role in health and medical decision-making and decision-making beyond health and medicine. Lastly, Ellen Markman, our discussant, is going to bring it all together and lead the live Q&A, right? And so thanks everyone for sticking around, and I look forward to your questions.
My name is Christine Laguerre from the Department of Psychology at the University of Texas at Austin. Today I'll be talking about perinatal risk and the cultural ecology of health in Bihar, India. This research is based on a partnership between my lab at UT Austin, SCOPE, which is the human-centered design firm, Project Concern International, which is a global NGO, and the funder is the Bill and Melinda Gates Foundation. Now, the perinatal period is associated with substantial health risks to mothers and infants. And the perinatal period refers to pregnancy, birth, and postpartum, and period right after birth. Now, the risks during the perinatal period, they vary in amount and kind based on environmental risk factors and access to high-quality health care. Maternal and infant mortality rates have declined rapidly around the world, but they continue to vary substantially both between and within populations. So for example, in 2017, the maternal mortality ratio, which is maternal deaths per 100,000 live births, was 917 in Nigeria, 145 in India, and only 3 in Finland. The infant mortality ratio per 1,000 live births was 77 in Nigeria, 32 in India, and again, only 3 in Finland. These rates also vary substantially within populations or countries. So for example, in 2017 in Bihar, India, the maternal mortality ratio was 165 and the infant mortality ratio was 35. This is substantially higher than the national average. We work in Bihar, which is a state, which is a primarily agrarian economy in northern India. And we're interested in the cultural ecology of health in order to better understand local beliefs and practices with the objective of designing more efficacious health interventions. Now, high levels of perinatal risk require strategies for reducing it and alleviating the anxiety associated with perceived threats. Now, all populations use a diverse repertoire of traditional or folk medical as well as biomedical health practices to respond to risk or to mitigate negative outcomes. The objective of the current research is to document and describe the complex, diverse, and wide-ranging health ecology associated with mitigating risk during the perinatal period. Now, there are traditional perinatal practices in all populations. All populations have folk medicine, for example. But we propose that the amount and kind of beliefs and behaviors are influenced by local ecologies of health and the amount and kinds of risk. So we would predict that the greater the risk during the perinatal period to life and health, the greater the ritualization and the more complex folk medicine is around this time period. The research that I'm presenting here was recently published in PhilTrans B, if you're interested in learning more details. Now, research on folk biological concepts has shown that introducing biomedicine into populations does not, in fact, replace traditional folk medicine or supernatural explanations for health. And instead, folk medicine and biomedicine coexist in a variety of complex and interconnected ways. We propose that perinatal ritual, like all ritual, is in part a byproduct of the hazard precaution system. This system is a response to, or operates in response to, both social threats such as ostracism, as well as physical threats such as threats of contamination and pathogen avoidance. Now, the function of perinatal rituals is to respond to high-risk contexts with the objective of avoiding danger primarily, rather than promoting health, which is not to say that perinatal ritual is not a response to or does not function to promote health, but the relative emphasis is on avoiding risk. This would be especially true in very high-risk contexts, such as Bihar. Now, traditional health practices include things like taboos, superstitions, religious and folk medical practices, as well as rituals, all of which operate as culturally sanctioned responses to perceived threat. Now, traditional medical practices, like those I just mentioned, share many of the same characteristics. They are socially transmitted. They operate based on principles of magical contagion or associational magic, and they're often opaque from the perspective of physical causality. One of the things that we would like to propose is that biomedicine is a new kind of ritual repertoire that coexists with traditional medicine. And we mean that from a lay practitioner perspective. So for the consumer of traditional medicine and biomedicine, both toolkits and explanatory frameworks are similar in that they are a suite of ritualistic practices. This project is part of a much larger research project that is called Project Rise, which is about harnessing ritual to improve service delivery and empower health workers. So the objective here is to better understand the cultural ecology of health in order to design more effective interventions. We use focus group discussions for this particular project, which involves getting groups of informants together to have conversations about health and risk during the perinatal period. We interviewed younger and older mothers in a number of districts in Bihar across religious groups, castes, educational backgrounds, as well as income levels. And those are the data that I'll be talking about today. We also did a lot of key informant interviews with local health influencers that are part of the formal health sector, as well as the informal health sector that we'll report in future papers. We examined the full perinatal journey. So this is the pregnancy period, childbirth, as well as the postpartum period after birth. All of these different points in time are associated with different sorts of risks to the mother as well as the fetus or infant. A brief overview of our results. We found that mothers, both younger and older mothers, reported wide-ranging taboos and superstitions believed to mitigate physical threats to mother and child. Miscarriage, birth complications, premature delivery were frequently mentioned concerns for younger and older mothers during the pregnancy period. It's worth noting that postpartum women or mothers and infants are considered impure. Thus, there are a number of taboos that function to prevent the mother and infant from contaminating others. This would include things like physical isolation of the new mother and baby, for example. We also studied a birth ritual, which is called chatti, which is very common in this region. It happens the 6th day after birth, and many of the procedural details associated with chatti are similar to other rituals around the world. It functions to initiate a new baby into a family, to change the status of the parents within the community. It also has protective functions. It appeals to divine protection and divine intervention to, again, protect the health and the well-being of the child. This ritual was of particular interest to us due to the potential to leverage what is already a very salient and important ritual within the community for further biomedical health intervention. Here's an overview of the practices that were identified during the pregnancy and postpartum period by younger as well as older mothers. You'll note that during the pregnancy period, the vast majority of the practices are oriented towards avoiding risk. I mean, overwhelmingly so. You see a more even distribution between health promotion and risk avoidance during the postpartum period. You also notice that the majority of the practices are in fact neutral to biomedical recommendations. A lot of them are also perfectly consistent with biomedical recommendations, which suggests a functional biological role of many of these traditional medical practices. And there are very, very few that are in fact inconsistent with biomedical practices, which suggests that very few of these actually need to be changed in any way, and instead could potentially be leveraged for greater impact and efficacy. So a few insights. The perinatal period is marked by an extensive number of traditional health practices. The large majority of these practices have the goal of avoiding risk, suggesting that perinatal rituals function as a response to perceived threat to health. Now, the extent to which health-related practices are explained as risk avoiding versus health promoting varied between different points in the perinatal period. And the extensive use of traditional medical practices for protection from both supernatural as well as physical harm in this region is consistent with previous research in, for example, South Africa and Haiti, which has revealed the use of traditional medical practices to protect people from supernatural threat. Witchcraft would be one example, as well as evil eye. We argue that recognizing similarities in function, for example, between traditional medicine and biomedicine has the potential to provide unique insight into how both healthcare systems function within local ecologies of health. Both traditional medicine and biomedicine operate as ritualistic remedies, or a whole suite of ritualistic remedies. They're socially transmitted, they're typically causally opaque from the perspective of the user, and are largely oriented towards mitigating risk. The vast majority of traditional perinatal health practices are in fact consistent or neutral with biomedical health practices. And future research should examine how the social capital associated with traditional medicine can be harnessed to improve the efficacy of biomedical health interventions. Now, although the vast majority of traditional medical beliefs and practices are neutral or consistent, there are a few that are inconsistent with biomedical recommendations. I'll give you an example of one. It's colostrum taboos. So in this region, colostrum taboos are very common, which basically entail expressing colostrum and discarding it, despite the fact that exclusive breastfeeding is very common in these regions. So it is a population that breastfeeds. It has colostrum taboos for a number of complex and interesting reasons. Now, instead of creating new rituals surrounding this period or new practices, in this case, we're just reframing how colostrum is perceived. So rather than as something that's considered potentially contaminating or hard to digest for the baby, reframing it as something that involves something of liquid gold. So emphasizing the health promoting properties of colostrum we have a very powerful impact on increasing uptake and revising this practice. And finally, we argue that a comprehensive understanding of traditional health practices can improve the efficacy of health interventions. These practices are largely not obstacles, but in fact are points of strength that can be built upon. and that future research on maternal and child health should continue to examine traditional medicine worldwide, a topic with tremendous potential to improve global public health that has been largely neglected in past research. Thank my larger team as well as my funders, and thank you for your attention.
Hi, I'm Zach Horn. Today I'm going to be talking about a new obstacle to vaccine uptake. In this talk, I'm going to discuss emerging trends and attitudes towards vaccination, especially in the shadow of the pandemic. Now, this won't be an empirical talk. Rather, it's going to be a synthesis of what I think of are core problems facing researchers attempting to increase vaccine uptake. I'll begin the talk by briefly noting challenges facing public health experts who aim to correct misconceptions about vaccines in 2019. In 2019, vaccine skepticism presented a significant public health problem across the globe. A global survey in 2018 found that approximately 13% of people believed that vaccines are unsafe, leading to over 40,000 cases of measles in Europe. Unfortunately, a number of researchers have found that efforts to debunk this and assure people of the safety of vaccines often can fail and may even backfire. And even if these misconceptions seem fringe, they had substantial consequences. In Samoa in 2019, 53 people, most of whom were children, died of measles from being unvaccinated. These obstacles prompted some of my research by my colleagues and I into how vaccines are presented in the news media. In particular, we are interested in examining how presentation of information in news feeds impacts perceptions of the dangers of vaccines. Now, unfortunately, hundreds of people have died from the flu in late 2019. And if you Google it, one thing that was really striking is even though the articles were often about the dangers of the flu at the time, the images typically presented with this information were pictures of flu shots. Now let's think about this, because typically if there were a salmonella outbreak in chicken or something like that, the picture shown with the news story would be of the culprit, so to speak, the chicken, not the life-saving medical treatment. So our concern in this project was, okay, if people are quickly scrolling through their news feed, they may associate the negative information with the picture of the flu vaccine rather than the disease itself. Now, the problems facing researchers in 2019 were serious and were growing ever more challenging because of the impact of social media, misinformation, and fractured public health messaging in some countries. Now, as everyone is well aware, in early March 2020, the scale of the pandemic, the scale of the public health problem facing the world went from challenging to massive and multidimensional. Now, our initial news media study really just pales in comparison to the new obstacles to vaccine uptake. And as a consequence, this has prompted me to refocus on what I perceive to be the largest obstacle to vaccine uptake in the United States. So I'll begin by giving us a sense of the state of the global pandemic. So this is Google's COVID tracker. And as of just a few days ago, there were over 14 million confirmed cases of coronavirus across the globe. A total of at least 600,000 people have died from coronavirus, and the death tolls grow daily in countries who have completely failed to control the virus, like the United States. The US in particular is now averaging about 60 to 70,000 confirmed cases a day. And as of now, over 140,000 people have died of the coronavirus, and these numbers are only rising. Consistent with the threat of the coronavirus, in polling over the last 4 months, Americans have remained at least somewhat or very concerned about the risk of getting the coronavirus. Now, inspired by the critical need for a vaccine, researchers and governments have fast-tracked antiviral treatments, and over 20 vaccines are now in development worldwide. So several researchers have noted that if we fail to control the virus and we don't have a vaccine, life is just not going to return to normal, at least as we knew it. Now, when we consider these numbers, it is then very striking that Americans appear to be uncertain about receiving a COVID-19 vaccine. So in this poll conducted by the Associated Press and the National Opinion Research Center at the University of Chicago, they found that roughly half of Americans would get a COVID-19 vaccine. In another poll, it was shown that only a quarter of African Americans would get a coronavirus vaccine, even though the pandemic has disproportionately affected them. Now, these trends are not unique to America, though they appear to be exaggerated here. So even in Germany, there are some fears over vaccines which have been linked to the rise of conspiracy theories, but they're not to the extent we see in the United States. So Americans are worried about getting infected, and yet only half of Americans and a quarter of African Americans report being willing to receive a COVID-19 vaccination in the United States. And so I think this brings into focus a seemingly puzzling picture of why this would be. This talk is my attempt to explain this puzzling set of observations and begin to identify the new obstacles facing researchers who are attempting to increase vaccine uptake. It's an attempt to explain what happened and what are the obstacles facing us. So I want to discuss how conspiracies and what I'll call reasonable vaccine skepticism may explain the troubling trends we're witnessing. Now, some news coverage might lead people to be tempted to explain what we're seeing by thinking that now half of Americans are conspiracy theorists due to widespread misinformation. But I think this explanation is improbable because people seem to be selectively skeptical about the COVID-19 vaccine, at least as of now. In general, in fact, 9 in 10 Americans support vaccines. So to get a grip on this, I first want to talk about how medical skepticism more generally might act as a barrier to vaccine uptake, and then I'm going to apply it to the COVID-19 situation. So first I want to walk through an example to demonstrate how conspiracy theories can impact vaccine uptake by screening off evidence. So here we have 2 nodes, a hypothesis and some data. In our example, we'll say the hypothesis is the belief that vaccines are dangerous, and the data is some studies showing vaccines are safe and effective. Now, in a model like this, evidence for the safety of vaccines will decrease the belief vaccines are dangerous. However, things totally change if we add a background theory to this network, like a big pharma conspiracy. This big pharma conspiracy is connected both to the hypothesis and to the data. And first, it implies the truth of the hypothesis, but it also includes the belief that big pharma seeks to fabricate evidence vaccines are safe in order to, say, make money. In essence, what this conspiracy does is sets up expectations about what kinds of evidence people are likely to see. Now, the consequence of this fact is that rather than countering a misconception that vaccines are dangerous, evidence for a safe vaccine actually supports the big pharma conspiracy, because that's exactly what the big pharma conspiracy kind of entailed and said would happen. And this in turn supports the belief vaccines are dangerous, rather than correcting the attitude. Now, that kind of process can prevent vaccine uptake. A full-blown big pharma conspiracy is not widely accepted, but the current state of things shows just how reasonable it might be for people to endorse what I'll call government medical skepticism, a kind of reasonable skepticism towards vaccination today. So this theory is very similar to the big pharma conspiracy, but better mirrors real aspects of how high-level public health decisions are being made in America. First, let's consider the data in this model. The data here is hypothetical, but it's very easy to imagine. An effective, purportedly safe vaccine is created quickly. Now, we know most vaccines take years to develop, and right now, many governments are promising a vaccine by the end of the year or soon after. This would be much faster than we've ever created a vaccine. So I want to pause and just let you reflect on this question. Imagine the Trump administration reported they've created a vaccine that's safe and effective in October, and that this vaccine would be available to you at a local licensed medical facility. So the question is, would you choose to receive this vaccine? And in talking to people, there's a lot of skepticism about receiving this kind of vaccine, Why is that? Well, part of the government medical skepticism kind of theory is that vaccines are dangerous when they're not sufficiently vetted, which is true, and that government officials might rush a risky vaccine into production, which is more debatable. Now, the consequence of this is that even if there is evidence for an effective, safe vaccine, that evidence may be screened off by this government medical skepticism background theory. Now, my hypothesis is the situation we're in right now in post-pandemic America roughly resembles this web of beliefs. It's kind of captured by this web of beliefs. The skepticism we see towards vaccines by Americans is the product of a medical skepticism which has been induced by government malpractice. Now, what is the evidence for this government malpractice? So in a recent article in The Atlantic, they point out that several things the federal government has done is going to give ammunition to vaccine skeptics. So first, the timelines of vaccine development are so fast that it seems like they must be cutting corners to make them. And if the dates are not actually hit, then this is just further going to discourage trust of medical officials because they're giving them false hope. Second, that a former pharma executive was in charge of the White House's new vaccine initiative and had 12 million of vaccine company stock options, though he divested from them. Again, kind of begs for a big pharma conspiracy, a big pharma speculation, and leads to distrust. And third, the CDC has really failed on many fronts and also has simultaneously been undercut by this administration. So as a result, it's really hard for people to know what to believe. Because, for instance, they flip-flopped on face masks. There were initial tests that were faulty, and that set us back hugely in testing and tracing. They pursued trials of unproven and ineffective drugs. And even more recently, the administration has blocked any new funding for testing and tracing while simultaneously arguing children should be in schools, regardless of the danger that poses to the children themselves, their parents, their teachers. So what effects will this have on our government medical skepticism theory? And how might it encourage more general conspiratorial thinking? Well, all of these things reasonably could lead one to not trust the government or those in charge of creating a vaccine. The administration has given evidence they cannot handle the pandemic and are in no way worried about the scientific facts. And they've said as much. And this will have serious implications for vaccination uptake, including vaccine skepticism that goes beyond the context of the immediate pandemic. So in sum, I think this pandemic has amplified or will amplify government vaccine skepticism. Now, how exactly would this kind of skepticism impact vaccination decisions? Well, landmark work from Powell, Weissman, and Markman in 2018 provides a fleshed out intuitive theory of vaccination decisions about what factors impact vaccine decisions and intentions. So what I've presented so far is really a toy model, but Powell and colleagues describe, test, and validate a model that has made several predictions which have been borne out about how beliefs are connected, how changing weights in some beliefs will affect other beliefs regarding vaccine intentions. So one thing they found among many of their findings is that medical skepticism doesn't directly relate to vaccine intentions, but it does relate to the belief that vaccines may have toxic additives, which in turn may make them dangerous. Second, they found that one of the best predictors of vaccine intentions was the perceived danger of vaccines, so a very intuitive result. Given the model of Powell and colleagues, if people feel that the government will rush a risky vaccine into use in the population, and simultaneously the government has failed to act according to our best science, we should expect vaccination intentions to be lower than they would otherwise be. So even if people do fear this disease, they might fear that the vaccine poses a bigger risk than the disease itself. This raises several interesting questions about how people will respond to vaccines that are developed in the United States versus other countries. So for example, one question this raises is, will people trust a vaccine from this administration? And how will that interact with political affiliation? We would expect in this highly polarized time it would interact with political affiliation, but the extent of that interaction is unknown. A second question is, would a vaccine developed in some other countries be universally trusted? Whereas vaccines developed in, say, the United States, or maybe South Korea or China, would those be trusted only by some groups of people? For example, only by Democrats or only by Republicans? A bigger worry I have that's created by this increase in medical skepticism that comes from the government is that it could beget general vaccine or general medical skepticism that extends beyond the case of the pandemic. So we need to develop new ways to think about and address these problems. Now, we're not going to be able to undo all of the damage this pandemic has wrought through social science alone, because many of the problems we're witnessing are directly due to governmental malpractice and thus are kind of structural problems. But we also need to realize what the landscape of the situation is and also understand what are the possible issues that could come up in this post-pandemic world. So in this talk, I've offered an explanation of this seemingly puzzling phenomenon that people fear being infected by the coronavirus, but they also seem to be uncertain or skeptical even of vaccination. And what I think this talk has shown is that there's a new obstacle. What I think is the biggest obstacle to increasing vaccine uptake is just overall increased skepticism about the safety of government-backed vaccination programs because of how the pandemic has been handled. And I hope this work offers directions for future research to address these important multidimensional problems. I want to thank my collaborators for their feedback on this talk and their inspiration in their work. And I look forward to your questions. Thank you.
Hi. Today we're talking about herbal medication and causal illusions. And particularly, so herbal supplements and medications are a booming industry, despite any real evidence for their effectiveness. One thing I'm interested in here is, why do people endorse the effectiveness of things that aren't effective, right? So the basic cognitive explanation is something like this, right? Where people take the medicine when they have a cold, then they feel better from their cold, and they go, oh, the medicine did it. However, what they're not really considering is a situation where they didn't take the medicine and they still get better, right? They're not thinking counterfactually. They're not thinking about what the control condition would be. They're not really thinking scientifically, right? They're just attributing causality to their actions. All right, so the way this works in a laboratory task is that you give, you present people a bunch of trials where there's sick people. They either take the medicine or they don't, and then they either get get better or they don't, right? And the way that you perhaps should be basing this on is that if the probability of getting better, right, is higher when you're taking the medication than they're not taking the medication, right? However, there's a lot of evidence suggesting that that's not what people necessarily base their causal attributions on, okay? So if you have a situation where everyone gets better 75% of the time, regardless of taking the medicine or not, so you get better 75% of the time when you don't take the medicine, and you get better 75% of the time when you do take the medicine. In both cases, people think, and so in that case, people think the medicine did something, right? Compare that to a situation when people are only getting better 25% of the time, right? Whether they take the medicine or not. In this situation, people don't think the medicine is that effective. So what that suggests is that people are overall focusing on just the overall outcome, like how frequently people are getting better. They're not doing this comparison. They're not looking at the change in probability of getting better or taking the medicine or not, right? This delta P, this change in that probability. They're focusing on just overall, are people getting better or not? And then if they are, attributing it to the medication, right? So that type of effect has been well established, but these studies usually just have completely novel stimuli devoid of people's any background beliefs to equate for their background beliefs, right? In typical cognitive methods fashion, right? What we're doing here is I want to go, okay, how do people deal with this kind of data, and how do they integrate that with their prior beliefs? Okay, so we're actually going to look at people's beliefs in hormonal medication specifically, and then see how they integrate that with new information about a novel hormonal medication. And then we're further going to see whether a sort of brief science education intervention can get people to more optimally integrate new data with their prior beliefs. Right, so for this study, we're looking at, we're manipulating that outcome density, that finding we were just talking about, where you compare, where everyone's getting better 75% of the time versus 25% of the time. But we're also, another effect from that same literature looks at, people's control of, of the sampling. So do you see patients who got the medicine, or do you see patients who didn't get the medicine? Okay. So, and here we're calling that the control. In 2020 here, because we have 40 trials, so they're either going to get the control of their sample, or they're going to get 20 trials of getting the medicine and 20 trials not getting the medicine, totally randomly presented. All right, we're going to ask them before this their prior beliefs and their experience with home medication. How effective do you think home medication is at treating the common cold, and how frequently do you take home medication when you have the cold? And here we just had 3 categorical options. Our cover story was to review individual reports from a large medical trial examining a new herbal treatment for the common cold, HerbXB. So they get 40 trials. We have information about a patient and whether they took the medication, and then they predict whether they got better, and you get feedback. Then we ask them, how effective was HerbXB? Would you take HerbXB if you had a cold? Then we try to calculate their remembered delta P, where we ask them all 4 cells of the contingency table. Right? How many people do you remember took HerbXB? And how many of those people got better? How many of those people did not get better? How many people did not take HerbXB and got better and not get better? Right? And then from these individual sort of reported memories, we can calculate, well, how much more likely in their memory was someone to get better who got HerbXB and who did not. Okay? Now, what it has to do with there is how much of their kind of reports, their memory, their recall of these things is affected by their prior belief, or whether they're not affected by their prior belief. Right. So, and we also, for the control, the people who have control over their sampling, we're going to look at how many trials they choose to review a case where someone got HerbXB versus not. Okay. And here, what we're testing for is how prior beliefs might affect bias in your sampling. All right, so here we're just showing the sensible thing where people who take herbal medicine more have stronger beliefs in it. That's all that's showing. And about half the people very rarely or never take it, and about half the people take it at least half the time. Here are main effects on the effectiveness rating. The basic, do you think this medicine works? And what you're seeing is a large effective outcome density, right? When people got better 75% of the time, people thought it was much more effective than when people got better only 25% of the time, despite, the delta P being the same in each case, which is 0, right? However, unlike the other findings, we did not see that having control reduces the causal illusion. Typically, when people have control, it might heighten the meaning of the non-medicine trials. However, in this case, we did not see that. Here we're looking at how the outcome density effect actually interacts with prior experience. So overall, people give higher ratings who had stronger beliefs in oral medication, which makes sense. But what you're seeing here is that everyone is affected by the outcome density. So everyone in the 25% condition shows lower effectiveness ratings, but the people who had higher ratings to begin with than their prior beliefs actually are more effective. And it's not simply a floor effect, okay? But we are seeing this interaction where the people in the middle get pushed around the most, which is interesting. All right. So then we're looking at here the remembered delta P, and frequently people remember pretty accurately that there should be 0 or very small. However, there is a spread, and also the outcome density effect does have an effect where people remember a bit more of a positive delta P when there is a 75% frequent of getting better. Right now, what's important here is the correlations between these different measures. Now, prior belief and delta P each are correlated with effectiveness, and that makes sense. However, they're not correlated with each other, okay? They independently contribute variance in the linear regression model to predict effectiveness, right? So delta P is being pushed around by something. It's not clear entirely what, but it's not being pushed around by people's prior beliefs, which was unexpected. So here now we're looking at the outcome density and confirmation bias, where, here we're just looking at the confirmation bias of the control condition, people with control. And what you're seeing here is that people who have stronger beliefs in herbal medication have much more biased sampling, where they're getting many more trials where people have medicine. 20 would be no bias, right? And 40 would be totally biased. And we have much higher, much closer to 40 for people who take a lot of herbal medication. So we are showing them a confirmation bias. All right. So we're seeing here is that we're replicating a standard effects of outcome density. We're not replicating a standard effects of the controlled sampling, right? We're seeing an interaction of prior beliefs and experience and outcome density, which is quite interesting, with people who take more herbal medication is affected more than people who don't take herbal medication. And the remembered delta P is independent of prior beliefs, and it correlates with perceived effectiveness. And also, again, people with strong beliefs in herbal medication show a confirmation bias in their sample. All right, so the next thing we're going to look at, can we use a brief science intervention to improve people's causal inferencing, to really focus on the difference between taking the medicine when they're not taking the medicine, and not just focusing on the frequent outcome. Okay, so here, to do that, we give some people instructions. We take them through the logic of randomized controlled trial and how important it is to compare a control condition to a intervention condition. And we make sure that they can explain back to us the logic so they really get it. Okay, versus people without the instructions. And everyone had control over their sampling and also has a 75% outcome condition. And we have the same measures as before, but then we also, at the end of their ratings, show them the true 2x2 table of the number of different trials, right? They had sampled different numbers, and we're going to show them this is how many people you sampled who had the medicine. Here's how many people you sampled that didn't have the medicine. Here who got better, who's still sick. And then they might, be able to see the 0 delta P in that contingency table that perhaps their memory had biased them against. And particularly perhaps the RCT instructions should help them take advantage of those contingency tables, because we used examples like that in the instructions. All right, so here we're looking at just their sampling, okay? Now, what you're seeing here is a big reduction in the confirmation bias when they get RCT instructions. So look at that most of the time, right? Look how the people with most of the time without the RCT instructions, their median is like 37 out of 40 trials with looking at, wanting to see people who took the medicine. But it's all the way down to like 22 when they get the RCT instructions. And you're getting effects across the board with people as well. So even the half the time and the rarely herbal medication takers still get even less biased in their sampling, right? So we have this big effect of sampling by the RCT instructions. Now, there is an effect in the actual causal inference, but it's a bit more subtle, right? So for causal inference, there's not an overall main effect of the RCT instructions, but there is an effect specifically for the people who take it at least half the time. Okay. Now, if we look at the second effectiveness ratings after they see the contingency table, where they get to see that there's a 0 delta P, right? There's very little effect. Now, there is a statistically reliable effect where on the whole, people do lower their ratings slightly, but it's very slight. This pattern overall is basically the same pattern as what you just saw in the previous slide. Further, and this is just showing that, people typically don't really change, or there's a slight in the other direction. But weirdly, in the second time we asked if they would take CarbXB, there's actually a few more people saying yes, right? Not much. So overall, this kind of second rating after you show them the real contingency didn't really do much. As a final piece of data to show you, we're looking at the correlation between delta P and their effectiveness ratings. And what you're seeing is the RCT instruction increases that relationship, okay? Which makes sense, because if you experience, right, because RCT is basically telling you to focus on delta P, right? And people are, and this is actually significant interaction in the regression model, right? So people are, when you give them RCT instructions, but people still have these kind of biased reports, because some people are, reporting that there was this, strong delta P. All right, so in summary, we have these RCT instructions, reduces sampling bias, especially with people with strong prior beliefs. And this has been robust finding across a bunch of experiments we didn't present. The RCT instructions has less effect on causal inference, and this actually hasn't been robust across different versions I didn't present, right? And that contingency table stuff didn't really do much. So overall, the causal inference integrates prior beliefs and new evidence. And so that's kind of rational in a sense, but it's not in a clearly optimal way. For example, what's really up with that outcome density effect? That's not, at least scientifically, how you're supposed to reason, right? And overall, right, we also are overall showing effects of the science intervention, right? Where people show confirmation bias in their sampling, but a brief science education intervention has this large debiasing effect, even though it doesn't have much of an effect on their causal inference, right? However, however, any kind of effectiveness about a basic science education intervention, in a way, makes this seem kind of different than the kind of most salient examples of anti-science, like the anti-vaxxers, the anti-maskers. I don't have really time to get into this, but generally, there seem to be some differences between people where some types of prior beliefs, people really seem to be based on just misperceiving the evidence, and other kinds of prior belief is about their social identity. And it's much stronger to change people's beliefs when it's about their social identity than it's just about the misperceptions of the evidence. But herbal medicines and supplements seem to be about the misperceptions of the evidence more so than other kinds of false beliefs about health.
Hi, my name is Amy Perforce, and today I'll be telling you about some work I've been doing studying decision making in black swan type events, which many health situations are. So as a motivation, consider this situation faced by a lot of parents nowadays, which is whether they should send their kids to school given the coronavirus. Now, this is in many ways what we might call a black swan problem. That is a problem where there are reasonable odds of having a moderate gain of something, but extremely low odds of having a major loss. You can replace losses with gains and the same kind of thing. And many health decisions have this form. So both decisions about sort of behaviors that have health implications, like riding a motorcycle, deciding whether to vaccinate or not, deciding whether to have certain surgeries, for instance, and of course many of the decisions we're faced with in the coronavirus are black swan type things. Now you might ask at this point, aren't black swans well studied? And indeed, if you Google it, it sure looks like it. Much of that work, though, is in economics and in psychology. If you look at actually experimental studies, there's actually very little where they look at things that have extremely low odds and the loss is catastrophic. So the odds rarely go below 1%, and the losses are generally not that bad. And so what I'm interested in is basically situations like that. Now you might ask, what about having very, very low odds or really bad things makes them qualitatively interesting or distinct from other types of decision problems? And I think there's two things. One is the fact of having very small probabilities has interesting cognitive implications, one of which is the problem of representational resolution. How do we represent these really, really small probabilities? And there's evidence that people appear to represent them in a fuzzy way and much more qualitatively, and so they're not exact. And one implication of this is that people might reason very differently about a situation like this, where they're choosing between two options, one with a risk of 0 and one with, say, 1 in 1,000 risk. They don't differ by much, but if they qualitatively, if they're encoded in a qualitatively different way, they might really try to avoid that 1 in 1,000, even though it's tiny, and even if it has greater benefit attached. Conversely, if you have two options where both of them have a tiny risk and the magnitude of the difference between them is large, but they're both very tiny, if people are representing that, they might actually treat them very similarly. So that's one implication. The other thing, though, is about the utilities. When the utilities get very bad, it's hard to know how to quantify them or estimate them. How do you quantify how bad is death or severe illness or disability? That makes it really hard to model, but also we don't really know how people think about that. So what I'm going to be talking about today is two sets of studies that address these. The first is about small probabilities, rather wanting to see whether people are sensitive to these tiny changes in magnitude, what that means about their risk preferences. And secondly, about sort of how they quantify and estimate utilities, particularly in the realm of vaccination. All right, so for the first problem, I'm going to be reporting on a series of experiments that all have very similar method. We take people on mechanical Turk, give them a random set of starting points. Each person gets only one. And they're told they get paid a bonus depending on how many points they have at the end to incentivize making a good decision. Make sure they really understood all of that. And then ask them each one question and one question only. So this is all between subjects. And we say, okay, you have this many points. Please choose between the following two options. And we don't tell them it's more risky or less risky. That's just for you guys. And then we just see what they choose. So what are the two options? Well, in one condition, which I call the one risk condition, the more risky option, basically, there's a gain of 15 points, so it's a reasonable gain, but a tiny, tiny risk of losing all the points. And in the less risky option, the gain is smaller, but there's no risk of losing anything. And the difference between them is about 10 and 10,000. Now, in the two-risk condition, it's very similar, except that this time, and in fact, the more risky condition is qualitatively identical, but in the less risky condition, this time there's a tiny, tiny, tiny chance of losing everything. So 1 in 10,000, right? The difference between them is, again, is very similar in magnitude, if anything, slightly larger in the two-risk condition. Now, if you put these into expected utility theory, you can see that they're qualitatively identical between both conditions. And the prediction is that if you have more than 5,000 points, you should choose the less risky option, and in the otherwise you should choose the risky option. The point is, though, that both conditions are the same expected utility-wise. So if people aren't encoding small probabilities, we would expect them to sort of treat the one risk and the two risk conditions as a qualitatively distinct way, because one risk has none and the two risk doesn't, and that they shouldn't represent the difference between the more risky and less risky option very precisely, which predicts that in the not one risk condition, people should be more risk averse because that's a zero risk, even though the risk of the other thing is very small and the gain is more. And it predicts that in the two risk condition, they should shift to being more risk seeking, especially relative to the one risk condition, even though it's actually much riskier. And it also predicts if people aren't encoding these things, they should make the same decisions regardless of how many points they have to lose. Whereas if they are encoding things, you should find no difference between risk conditions, and also they should change their behavior as the number of points they have to lose changes. All right, so what happens? First, let's look at the choices people make in the one risk or two risk condition. As you can see, they do shift to being more risky in the two risk condition, and you can quantify the magnitude of this shift. That's basically the size of that arrow there. And also, if you look at how they change their behaviors as a function of the starting points, there's really no difference in either the one risk or the two risk condition. They're indifferent to the magnitude. So basically, all of the predictions of the theory that they're not encoding small probabilities are upheld. Now, you might ask how robust this is. So I showed you one experiment where the magnitude of the risk was basically 1 in 1,000. So I did 4 more experiments verifying this. So there's one where it's 1 in 100, one where it's 1 in 10. In both of those, that shifts the expected values, so you should choose less risky in both conditions. But again, both conditions are the same in terms of the pattern. And in experiment 4, I made it very, very small, 1 in 10,000. So this is tiny, tiny, tiny. And this says in this condition, you should actually choose the more risky option all the time. The real question is whether you see that risk shift in all of the conditions, where people are more likely to choose the risky option in the 2-risk condition. So as a reminder, that is what we saw in experiment 1. You saw that risky shift. See the same thing in experiment 2, qualitatively very similar. In experiment 4, people are indeed choosing the less risky option more, but you still have that risk shift. And in experiment 3, they're choosing the riskier option more, but still also having the risky shift. So basically, we're seeing the risky shift in all of the conditions. And also in all of the conditions, we see an indifference in magnitude. None of these things are significant. So basically, the predictions of what we'd expect if people aren't encoding small probabilities are upheld throughout. And this does suggest that we would expect people to be more risk-seeking when both options have non-zero risk. The interesting thing is, even if that risk is minuscule, even if it's 1 in 10,000, or indeed 1 in 100,000 in the 2-risk case in one of the experiments. And so one implication here is that perhaps risky health behavior comes from this perception. If the idea is you can't actually get it to 0, then why bother? And that's why people act very risky sometimes. So that's the first part of today's talk, talking about the implications of small probabilities. Now I want to move on to this question about quantifying the utilities, and I want to do it in a situation that comes up all the time and understanding how people reason about vaccination. So let's try to apply expected utility theory to vaccinations. You have choices, 2 choices, don't vaccinate or vaccinate. If you don't vaccinate, you pretty much have to figure out what's the chance of getting a disease like whooping cough that you could have vaccinated against. How bad is that? And if you do vaccinate, then the question is, well, what's the chance of some negative outcome, say autism? How bad is that? There's maybe some milder outcomes like high fever, which slightly higher chance, but not that bad. And then, of course, a certain chance of no change. So this is the decision you're faced with. And what we wanted to do is basically just estimate all of these things. What do people think about these probabilities and the utilities? Not what are they actually in the world, but what do people think they are? Because that's what they're probably using to make their decisions. So we asked a bunch of people again on Mechanical Turk to estimate these probabilities. So first we asked, what's the probability of a child developing whooping cough if they don't get a vaccination? You can see this distribution of responses. You can see it's all over the map. The modal one was about 5%. We also asked them what's the probability of developing autism because of a vaccination. Somewhat nicely, the mode is 0, but there's a fairly substantial second mode, which is fairly of 0.01. And this actually creates a situation that's pretty analogous to the 1 risk versus 2 risk conditions in the first half of the talk, where the 1 risk is if they believe the probability of getting autism is actually 0, then we can drop that out, and the vaccinate decision looks like something with at least no real catastrophic risk. However, if they do think the probability of getting autism is non-zero, then it ends up looking a lot like the 2 risk condition. The don't vaccinate option is very similar, but the vaccinate now has this other tiny chance of this autism outcome. So now the question is, well, what are the utilities? How catastrophic are these things? And we asked people to estimate these by having them answer relative questions. People are really hard at putting a single objective number, but it's a lot easier to say how much worse something is than something else. So if you ask people for whooping cough or high fever, which is worse, you can say most people thought whooping cough was worse. And if you ask those people how many times worse it is, you can see that the modal response is about 10. So that suggests that, for our numbers, we'll put in that the utility of whooping cough is basically 10 times the utility of fever. These are all negatives, so it's 10 times worse. So putting those numbers in, all that matters is the relative things. So I said, say fever has a utility of -100, then that means whooping cough is going to have a utility of -1,000. All right, how about autism? Now, most people said autism was worse than whooping cough. And if you actually ask them how much worse is it, most of them, the modal response was that it was 10,000 times worse. Again, if you put those numbers in, then what that means is basically that this sort of utility of autism down here in the lower right corner is negative 10 million. All right, now let's just calculate those numbers. If you calculate these expected values, it suggests that if you see the probability of autism is 0, then you should probably vaccinate. If you see it as not, and you think autism is that bad, then you definitely shouldn't vaccinate. Now, we asked whether people actually, if given these numbers, they reason in accordance with expected utility theory. So if you ask them just without the vaccination framing, with just the numbers, indeed they do. They choose to vaccinate if given the numbers in the 1 risk condition, and in the 2 risk condition, if you give them those numbers, they choose not to vaccinate. Again, it was without the vaccination framing. This is just the numbers. So as long as people think in these ways, the implication is, even by expected utility theory, they shouldn't be vaccinating. And this is very robust. If they think autism is that bad, even with a tiny PA, a tiny probability of it, then the reasoning is the same. And so what this all suggests is that if we want to change people's minds about vaccination, instead of trying to change their estimates of the probability of autism, maybe the thing to do is change their utilities. Do education about how whooping cough, measles, and stuff are much more terrible than they think they are, and possibly that autism isn't quite so bad. So to sum up today's findings, we basically did 2 different types of studies. One, looking at the implications of small probabilities, suggested that people really reason qualitatively differently about something that has any risk, even if it's tiny, 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 and then as implications for their risk aversion. And secondly, that if you're looking at sort of people's reasoning in a vaccination context, it suggests that that some of their behavior may be driven by their sense of how bad autism is relative to whooping cough, and that might be a target of intervention. All right, thank you very much.